Evening.
Hold on just a second, Carly. You're about two steps ahead of me. We're going to meet our first guest tonight, Carly Nagel, doctor of physical therapy. Carly Nagel is an experienced and dedicated doctor of physical therapy with expertise in polytrauma rehabilitation, lymphedema management, and pelvic floor therapy and biological Cal Poly San Luis Obispo, and a doctoral degree in physical therapy from the University of Colorado. Outside of physical therapy, she enjoys camping, reading, and being a mom to her two young children. So, Carly, all right, take it away. It's your turn.
Thanks. So good evening / afternoon, everyone. My name is Carly Nagel. I am a pelvic floor physical therapist. I have worked with mostly active duty for 13 plus years. I'm also a polytrauma physical therapist too. So I have lots of experience in this setting. Go ahead and next slide. There. So this is in no way the opinions of my employer, nor did I use any official work time to put on this presentation. Next slide. I do want to make sure that everyone is aware of what this presentation will include. So we will be seeing images of the pelvis. These are all going to be plastic models or illustrations. There will be no actual human pelvises. And then we will discuss the body's trauma response, as well as normal functions of the pelvis, including bladder, bowel, and sexual function. Go ahead, next slide. And so today I'm hoping that you leave this presentation understanding what physical therapy or what pelvic health physical therapy is. And pelvic health physical therapy and pelvic floor physical therapy are interchangeable. Pelvic floor physical therapy is kind of the original term for this type of physical therapy. However, we don't just treat the pelvis. We treat the abdomen and the bones and the hips and everything related to the pelvis. So it's more than just the pelvic floor. I hope that you will be able to describe what pelvic floor physical therapy is and go into any potential pelvic health physical therapy exam, knowing what to expect and be well educated on what you feel comfortable doing. Go ahead and next slide. We kind of already talked about this. So pelvic health physical therapy / pelvic floor physical therapy, we address all dysfunctions of the pelvis and the abdomen from a musculoskeletal standpoint. Go ahead and next slide. So because the pelvic floor and the pelvic girdle and the abdomen have such an influence on multiple different functions, we treat a ton of different diagnoses in pelvic health physical therapy. It's not just, oh, I pee when I sneeze, or I've had a baby or something like that. We see people who have not been pregnant before. We see people who have pain issues. So we can subcategorize these into different subgroups. So pain diagnoses, like pain with intercourse, pelvic pain issues, and then urinary issues. So stress incontinence, urge incontinence, overactive bladder, bowel issues, so constipation from multiple different standpoints. And then more of the orthopedic diagnoses. These are going to be more of SI joint dysfunction, and then gynecological issues like prolapses or pregnancies. Next slide. So the pelvic floor is a series of lots of different muscles that create a hammock on the base of the pelvis. So I added little arrows here pointing to that hammock of muscles. So that hammock of muscles support the pelvic organs above it. So from I believe the next slide has, go ahead and next slide. Well, okay, the next slide. We'll circle back to that. So the pelvic floor is a series of lots of little muscles that all work together. So you have layers of muscles, superficial muscles and deeper pelvic floor muscles. When you contract the pelvic floor, it is also a layered contraction too. So we think of pelvic floor exercises being Kegels. So a Kegel is just another word for a pelvic floor contraction. So a Kegel should be both a closure and a lift. And we can see in these models the superficial pelvic floor muscles, and then from the top down, we see more of the deeper pelvic floor muscles. Go ahead and next slide. So here we come back to that cross section of the pelvis. So we have the front side on the left hand side and the back side. So your bottom and your spine on the right hand side. So from front to back, you have the bladder, which is the little BL right there. You have the vaginal canal that crosses through the pelvic floor up to the uterus. And then the R is your rectum. So you have a curve called your anorectal angle that curves off to the side. And that exists because your pelvic floor muscles actually wrap around it and create that angle. So your pelvic floor, because you have your rectum, your vaginal canal, your urethra all passing through it, your pelvic floor plays a really important role in bladder function, bowel function, sexual function. So it's not just, oh, I pee myself and that's it, or oh, I have pelvic pain and that's it. A lot of times we're seeing combinations of lots of different symptoms. Go next slide. So every muscle in your body needs to contract well, relax well, and stretch well. Your pelvic floor is no different. So when we think of pelvic floor exercises, a lot of times we just think Kegel, 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 and sometimes that's not the right thing that we should be doing. So yes, a contraction of the pelvic floor will help to hold in urine. It helps to actually cue the bladder to relax. So that if you're rushing to the bathroom, your bladder's not contracting, expelling its contents. It helps to hold in feces and it helps with an orgasm. And then in terms of relaxation and stretch, your pelvic floor also needs to be able to release urine, to cue the bladder to contract appropriately, to help push out feces, and for comfortable penetrative intercourse. Go ahead and next slide. So when we have a trauma situation, your pelvic floor responds. So your pelvic floors, go ahead and next slide. Your pelvic floor naturally, normally contracts during a fight or flight response. That is a normal response. What is not normal is your pelvic floor living in that tight position. So a stress response can be from a real threat, a memory of a threat, or a perceived threat. And your pelvic floor is just one group of muscles that responds to that. But your pelvic floor in particular is this hammock shape. It's not a jointed muscle that I can just say straighten your arm and that will stretch your biceps. Your pelvic floor, because it's this hammock shape and it's not jointed, you need to fully relax it and gently push down to get it to actually stretch appropriately. So sometimes when it's driven into a tense position, it can be really hard to get it back to a relaxed and more stretched position. Go ahead and next slide. Now, pelvic pain a lot of times is associated with pelvic tension. So that's why we see that inability to relax and stretch can lead to pelvic pain. It can also lead to bladder issues and bowel issues as well. So when we're considering PTSD, um, one of the main aspects of PTSD is the re-experiencing of a traumatic event. And so if your body responds the same way with that perceived threat or that remembering of a threat, it's going to drive your pelvic floor more into a tense and overfired position. Which, if you're able to do a body scan and check in with your pelvic floor and relax it, great. But a lot of times we have issues doing that. Go ahead and next slide. Now, there's been quite a bit of research on just physical activity in terms of management of symptoms associated with PTSD. These tend to be more generalized exercise, so breath work, yoga, resistance training, mind body association, and those have all been shown to help improve symptoms of PTSD, depressive symptoms, interoceptive awareness, and quality of sleep. So physical activity is really important. Pelvic floor on the physical therapy, on the other hand, focuses a little bit more about the specific function of the pelvic floor. Go ahead and next slide. So, pelvic health physical therapy is just another adjunct treatment option that may help patients um, with the somatic symptoms associated with trauma. The nice thing about if we can address the physical symptoms of stress, we typically also feel less stressed too. So it's not always just a top down approach. Addressing the somatic symptoms can also help bottom up too. Go ahead and next slide. So my one of the big things that I want to address in this presentation is fully understanding and having a good education about what pelvic health is going to look like. So a lot of people are concerned about are we going to do a pelvic exam, or is this going to be re-traumatizing? So the more information that you have, the better it is that you can self-advocate for yourself, but also being aware of what potential triggers there might be. So go ahead and next slide. So we are concerned about the big picture. We want to know all of the things. There is never any TMI in pelvic health physical therapy. We want to know about your hip injury 5 years ago. We want to know about any back pain that you're having. We want to know about pregnancy history, surgical history. We want to know about what traumas you have been through, if you feel comfortable sharing that with us. We also want to know what your bladder function looks like, how often you pee. Are you making it to the toilet? Are you leaking when you're coughing and sneezing? Does it hurt to pee? Do you have to push to pee? We also want to know bowel symptoms. What does your poop look like? Are you straining to have a bowel movement? Do you have hemorrhoids? Things like that all give us a good idea of what the issue is. We also want to know, is intercourse painful for you? Are you comfortable having intercourse? Are you able to orgasm appropriately? Those are all things that your pelvic floor actually plays a really major role in, that we don't want to just push off to the side and ignore. We want to actually talk about those things and address those things. Go ahead and next slide. So an examination is, we can categorize this into three separate things. We want to know what, and this is the physical side of things. So we already talked about history, subjective, and then we want to know if your the alignment of your joints is contributing to your pain, if you have irritation along certain joints in your pelvis, which we'll talk about in just a second. And we want to look at hip strength, hip flexibility. We want to look at core strength. And we also want to do some degree of an assessment of what your pelvic floor is doing. And we'll talk about how we do that in just a second too. Go ahead and next slide. Yeah. So this is a picture of the pelvis. Your pelvis is made up of 3 different joints. So you have your sacroiliac joints along the back side, and then you have the pubic symphysis on the front side. I got a slew of questions right before this, and I did see one of them was asking about the tailbone. Your tailbone is an attachment for a lot of your pelvic floor muscles. So a lot of times we can see tailbone issues associated with pelvic floor tension as well. Go ahead and next slide. So the alignment of your rib cage and your pelvis is really important for interabdominal pressure control. So if we think of your abdomen with a top, which is your diaphragm, a bottom, which is your pelvic floor, and the abdominal wall that wraps around, it's kind of like a can or a canister. The alignment of that rib cage and the pelvis is really important for allowing the diaphragm and the pelvic floor to work appropriately, and allowing the pelvic and allowing that deep abdominal wall to fire appropriately too. So we're going to look at posture and alignment. Next, I just hit the next slide. Next slide. We also want to see what happens when you actually move. That you might look great just standing there, but that might not be when you have your symptoms. So we also want to see what your body might be doing with physical activity. So we'll look at we'll have you do pre-running screens and look at and see how you're actually moving. Go ahead and next slide. One aspect of dynamic posture isn't just like how we're running, but it's also how we're breathing. When we are in a stressed state, we typically don't breathe correctly. We a lot of times breathe with our accessory muscles, and we tend to hinge the rib cage over or at the junction between the thoracic spine and the lumbar spine. So it just kind of hinges up and down, versus your rib cage should expand 360 around. It should open and close. And so that is also very important for pressure control within your abdomen. And so we want to make sure that you're well skilled at belly breathing, and that how you're breathing is not actually contributing to your symptoms. Because also, if we breath hold a lot, so if we strain and hold our breath with simple things like rolling over in bed, picking something up, or with exercise too, that will also increase interabdominal pressure. So we also want to make sure we're not breath holding with this. Go ahead and next slide. We want to look at all the hip muscles. So your hip muscles aren't just hip muscles. You have some hip muscles that are also pelvic floor muscles. So your obturator internus, which will not be on a test or anything, is a hip rotator, but it's also a pelvic floor muscle. So it'll fire with a Kegel, but it will also fire to externally rotate the hip. So sometimes a prior hip injury could actually contribute to some pelvic dysfunction too. Your piriformis sits right next to the pelvic floor as well. So your and the little arrow is on there is where the obturator internus is. But one of the questions was about piriformis and piriformis syndrome. Yes, your piriformis can definitely contribute to pelvic floor issues, and vice versa too. So the piriformis and the coccygeus muscle sit right next to each other, deep in the glutes, and your sciatic nerve actually runs right through that area as well too. So if you have tension through your pelvic floor, you typically also have tension through your piriformis, and that can put pressure on that nerve and can contribute to pain as well. Next slide. So this is a good picture of what I was talking about, what that canister should look like. So your inner abdominal wall is what we're most concerned about in terms of pelvic floor physical therapy, because that's going to be what actually controls pressure within your abdomen. And so if that abdominal wall isn't strong from whatever reason. So it could be from a prior pregnancy, it could be just from a chronic issue, it could be from a strain. If your inner abdominal wall isn't firing like it should, we tend to try to compensate with a breath hold and by flaring the rib cage up. And what that does is it increases inner abdominal pressure, and that pressure goes to the path of least resistance. That pressure typically will go to the bladder and potentially cause leakage. It will push on the pelvic floor, which your pelvic floor, remember, will respond to a cough, a sneeze, things like that. It will contract to stabilize and prevent leakage. So if we are breath holding and increasing pressure, kind of like a cough or sneeze, your pelvic floor will respond by tensing. If you are already tense through your pelvic floor, that could be an issue. That can potentially cause pain. Uh, next slide. And so this is where I was discussing. We also really want to know what your pelvic floor is doing. We can kind of assume sometimes that your pelvic floor might be overfired or might be weak. Now, weakness and tension often go together. So tension does not equal strength. You can have a very tight pelvic floor and it could be weak. And we often see that. It normally doesn't come with laxity. So, how do we assess what the pelvic floor muscles are actually doing? We often do, with the permission of the patient, do an intervaginal exam. This does involve taking pants and underwear off, and it does involve a finger within the vaginal canal, pushing on 3 different areas internally to see, does it hurt when I push on it? And then can you contract, relax it, and stretch it appropriately? Go ahead and next slide, and we can see a little visual of that. So there's no speculum, no stirrups. We're not gynecology. We're not going to look at your cervix. I can't PT a cervix better, nor do I think that that's the issue that we see most. So the inner through the vaginal canal, we can push through the vaginal wall to put pressure on your obturator internus, your levator ani, and your coccygeus muscle. So those are 3 kind of main muscle groups that can potentially overfire and cause pain. If we see pain during the exam, then that may lead us to then have you do inner vaginal stretching at home, which we'll talk about. So whenever we do a pelvic exam, it's always for a purpose. We're not going to make you come and do like pelvic exam after pelvic exam after pelvic exam. We always want to make sure that there's a clear reason to do a pelvic exam, and that obviously we have permission from the patient. Go ahead and next slide. So you can say, that's great. I still don't want to do a vaginal exam. That is totally okay. So next slide. There are other options for assessing what the pelvic floor is doing. So one of my favorite ways to examine but also treat the pelvic floor is called a transperineal ultrasound, which is what this picture is showing. So a regular ultrasound, not the wand that goes inside the vagina at all, just the regular round ultrasound is placed at the vulva. And it gives us that cross section of the pelvis. So the one that we saw when we were looking at the anatomy, and we could see the bladder, the vaginal canal, that anorectal angle, we could see all of that in real time and see, are you contracting, relaxing, stretching appropriately? It's a great assessment that is a little bit less invasive. Now, if that still feels like that might be triggering, then we could potentially do a trans-abdominal ultrasound and visualize the bladder and see if the bladder is lifting or descending with a contraction or a push. We can do solely external, so we can potentially push around the sit bone, which is where the pelvic floor muscles attach into, to see if that's painful or reproduces any of your symptoms. Or we just don't have to do a pelvic exam at all. Sometimes I'll instruct patients on how to do a self-exam at home if they feel comfortable with that. Sometimes we just talk about it and have them just try independently to move their pelvic floor. So the purpose of pelvic health physical therapy is to help. It is not to re-trigger. So it that's the last thing we want. And so we will ask you lots and lots of times if it is okay and how you're feeling. And we want to make sure that you feel safe in this space. Go ahead and next slide. So after the exam, what do treatments look like? Go ahead and next slide. So one of the main treatments we have for pelvic tension is manual therapy. There are lots of different types of manual therapy. This picture is showing trigger point dry needling, which is an option. There are some states that do not allow physical therapists to do a dry needling, but all federal facilities allow dry needling, and most states do. So that's an option. But then there's also things like massage and pressure and trigger point releases and lymphatic drainage massage, visceral massages. There's lots of different options for reducing tension via mobility. And next slide. And so one of the my big thing is making sure that patients can leave my clinic knowing how to treat their own body, because pelvic tension and pelvic issues aren't just a one time thing. It's like saying, oh, if I massage a knot out of my shoulder, it's never going to come back. Your pelvic floor, remember, responds to stress. So if you have a really stressful week, your pelvic floor might tense up. But it's knowing what's going on and how to treat it. That's a bigger win. So these are pictures of tools. So there's pelvic wand, dilators, all tools that can help with pelvic floor mobility. And there is also the option for doing self mobilization with your hand, or having a partner help you do that too. Sometimes that's a nice transition from independent mobilization to taking what you've gained and transitioning it to hopefully pain-free intercourse. Go ahead and next slide. There's also biofeedback. So biofeedback solely just means that there is some sort of response that is telling you how well you're contracting, relaxing, and stretching your pelvic floor. So this is a picture of a surface EMG unit. So it uses a little sticker EMG that we place on the pelvic floor, or superficially, so outside of the vaginal canal. That will read a contraction of the pelvic floor and give you a visual feedback. One very simple way to get biofeedback is is just using a hand mirror. So looking down there and seeing, does my vaginal canal actually kind of close and lift when I do a Kegel? And does it open and kind of bow out as I push out? That's a really easy and very informative way of self-assessing your pelvic floor. And then we can always use the ultrasound machine too to assess the pelvic floor, assess and provide feedback for the pelvic floor. Go ahead and next slide. We also, remember, we're concerned about the abdominal wall too. So we can use ultrasound to look at the abdominal wall muscles. And a lot of times you can overfire your six-pack muscles and your oblique, but that deep abdominal wall that kind of pieces out and doesn't do what it's supposed to be doing. Having an ultrasound will ensure that you are actually firing that deep abdominal wall well. Go ahead, next slide. And we can go ahead and next slide, because we already talked about that. We want to make sure that you are using your deep abdominal wall well. So this is a point that I want to break into a little bit of self-treatment. So your diaphragm, remember, sits on the top of your abdominal cavity. The pelvic floor is at the bottom, and the abdominal wall wraps around. So when you breathe in, your diaphragm descends down. And that increases inner abdominal pressure just a little bit. And your pelvic floor should respond by relaxing and stretching and accommodating that pressure. When you exhale, that diaphragm lifts up and your pelvic floor actually raises up too. So, one exercise I really like to give patients is pairing pelvic floor movements with your breathing. So, utilizing that normal connection, remember, diaphragm and pelvic floor should act like a little piston. Um, and having them do that throughout the day. It's a really nice way to check in with the pelvic floor. It's very meditative in nature, meaning that you need to be present in your body to do it correctly. So if you feel comfortable doing it, I want everyone to take a nice deep breath in. And on the exhale, I want you to do a Kegel. So squeeze your pelvic floor and exhale. And then on the inhale, I want you to push your low abdomen out and visualize that pelvic floor descending down as you breathe in. And then as you exhale, you're contracting again. So exhale, contract, inhale, push out. Think of your abdomen like a balloon. When you're inhaling, the abdominal wall expands as well as the pelvic floor expanding out. And then as you exhale, it all closes down and lifts up. So we don't want to villainize a contraction of the pelvic floor. It's good. It's normal for that pelvic floor to contract. So doing an exercise like this, where it takes you through the full range of movement of the pelvic floor, while also doing some abdominal wall engagement, addressing the dynamic posture of the rib cage as well. Because if you breathe in and you flare that rib cage up, it's going to be really hard to drop that pelvic floor. So always think belly breathing when we're doing this. But it's a nice way to check in with the pelvic floor and get a good release. Go ahead and next slide. Okay, probably. We also want to make sure the core is strong. So we do kind of your standard core exercises too. Go ahead, next slide. And so this is the visual of that piston-like motion of the diaphragm and the pelvic floor, and what you guys were just doing when you were breathing. So go ahead, next slide. And like I said before, we don't want to villainize a contraction. Kegels are great. It's just not the only exercise that we need to do. And often we don't need to do them. But doing a contraction of a muscle does often help to relax the muscle. So if you think of tension through your shoulders, if you shrug your shoulders up and squeeze them, squeeze them, squeeze them, and then you let go, that helps to cue the muscles to relax. So if you're only thinking, okay, I need to relax, and not have this tension, sometimes that's hard to do. If you go into that tension first, it's easier to then trigger that relaxation and stretch of the pelvic floor. Go ahead and next slide. So I mentioned earlier that your hip muscles, a lot of them double as pelvic floor muscles. So tight hip muscles can potentially cause pelvic floor tension as well, but also is a nice way that you can non-invasively stretch your pelvic floor. That if you're keeping your hips nice and mobile, that will also help to reduce tension through your pelvic floor as well. Go ahead and next slide. And then education. This is like the bread and butter of pelvic health physical therapy. It's us teaching what you don't know about your body. That if you have questions, concerns, if you have normalized that this pain is normal, this leakage is normal, it's understanding what's normal and what's not normal. So we'll do a lot of education about just healthy habits, but bladder education, bowel education, and sexual health education are our big three. Go ahead and next slide, and we'll see a visual of so bladder education. Now the handout or the questions that I got, there's quite a few about bladder leakage. And so remember, your pelvic floor isn't just a response to sexual activity. It's if you have pain with intercourse, you can also have bladder leakage. You can also have bowel dysfunction as well. You can also have hip pain as well too. It's all connected. So we can't just put on blinders and only look at the bladder or only look at the rectum. That we need to look at the big picture. So with bladder leakage, it's typically divided into two different types of leakage. So there's urge incontinence, and that's the, oh my gosh, I really got to pee and I'm rushing to the bathroom and I can't get there in time and I have some leakage on the way. And then there's stress incontinence. So, stress incontinence is the increase in inner abdominal pressure. So, that would be like coughing, sneezing, breath holding with physical exercise. And I have leakage from that. So, a lot of times it's not just one or the other. A lot of times you can have both. Now, remember, your pelvic floor helps to control what your bladder is actually doing. It doesn't just close things off, it also helps to cue the bladder. So you have these reflexive loops called Bradley's loops that when your pelvic floor contracts, it actually sends a little signal up to your bladder, telling your bladder to relax and chill out and not to expel its contents right then. So if you are breath holding and just panicking, rushing to the bathroom, that's going to amp up that sympathetic nervous system and it's going to make that bladder really reactive. But if we can cue that bladder to calm down with a nice pulsed pelvic floor contraction, which is what this handout is showing, this controlling your urge, that will help calm that urgency down from that peak urgency down so that you can then calmly walk to the bathroom. So some of this is just changing habits and knowing kind of what to do. Now, stress incontinence, that's more of pelvic strength. So if you have weakness through your pelvic floor, you should be able to contract your pelvic floor and feel that uplift, and you should be able to hold it for 10 plus seconds. If you cannot, then doing Kegel exercises would be important while also making sure that we're relaxing and stretching the pelvic floor too. Because we would never go to the gym and do like 100 hamstring curls and then never stretch our hamstring. If you're going to do Kegel exercises, we also need to make sure we're relaxing and stretching that pelvic floor too. So that breathing exercise would be a good one to do. With stress incontinence, if you do an intentional Kegel and squeeze and lift and maintain that uplift through a cough or a sneeze, you should be able to control that leakage. If you are not, you should be seeing a pelvic health physical therapy or therapist. And then what's normal in terms of bladder function, we should be going every 2 to 4 waking hours. We shouldn't be going past that 4-hour mark because then that teaches our bladder out of its normal urge responses. And I did have one question about like pilots. The worst. So meaning that you need to have access to a bathroom every 2 to 4 waking hours for your bladder to actually function properly. Now, you can train your bladder out of that, but that is also creating more tension through your pelvic floor because what cues the bladder to not expel its contents? That's your pelvic floor. So you are just creating a lot of overfiring of your pelvic floor. Or there's tactical dehydration. That is also not good too. Having really concentrated urine will irritate the bladder lining and potentially make urgency worse. And I've gotten a bit of a tangent with the bladder control. I think we only have two more slides and then we'll get to questions. So next slide. Bowel function. So your pelvic floor wraps around your rectum. So when you are straining, that increases inner abdominal pressure. And remember that increase in inner abdominal pressure cues the pelvic floor to contract. What we should be doing is breathing through it and gently pushing down to stretch the pelvic floor. If you are straining, you're typically contracting the pelvic floor, which essentially is working against yourself from having a bowel movement. Now, there's other types of constipation. So you can have constipation from bowel motility issues, from what you consume. But in terms of outlet constipation, your pelvic floor it plays a big role in that. Go ahead and next slide. And then sexual health. So it is not normal to have pain with intercourse. So if you have pain with intercourse, you need to see a pelvic health physical therapist or a provider. Ways to help with progress past pain with intercourse, there's obviously lubricants, but most of the time lubricants don't do the job. Most of the time it's a pelvic tension issue. But there are also other things like the O-nut that's pictured here that will limit the depth of penetration, which can be a nice transition into penetrative intercourse. Using the pelvic wand or stretching internally beforehand can be really helpful. But also making sure that your pelvic floor, we don't, with intercourse, you don't want to just relax and think relax, 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 because that absolutely is not going to help. Your pelvic floor is meant to move during intercourse, so understanding that that it's okay to contract during intercourse, but then also relax during intercourse too. And go ahead and next slide. With all of that, every PT exam and treatment is going to look different based on the needs of the patient and the goals of the patient. So don't feel like if there's something out of here that you did not feel comfortable with, don't feel like that precludes you from getting help with physical therapy. Go ahead and next slide. And so that brings us to questions. I also put the APTA has a provider search on its website. So if you want to, you can search for a pelvic health provider. A pelvic health provider is just like any other provider. If you do not click with that provider, if you do not feel comfortable with that provider, leave that provider and find somebody that you feel comfortable with.